Dr. Likhit?
Sure.
Yeah. Please present your case and then we will go on from there.
Dr. Likhit, I'll be unmuting you just a minute. Yes. Yes, you are unmuted, Dr. Likhit. Please go ahead.
Okay. Good evening, everyone. I'll be sharing my screen now. Good evening, everyone. So my presentation is visible to everyone?
Yes, it is visible.
Okay. So myself, Dr. Likhit. I'm ID fellow at Dinanath Mangeshkar Hospital. So today I'll be presenting you case regarding AIDS in case of human metapneumovirus. So this case was presented in September 2024. So a 48 years old female patient with a known case of diabetes, hypertension, hypothyroidism was admitted with the following complaints. So she was presented with the fever, cough, which was dry, dyspnea on exertion since 4 days. So on arrival in ER, she was hypoxic. Saturation was 69%. So initially was started with NRBM, and as a protocol of CAP started on doxy, monosafe, and fluvi. So then was day one lab was sent. So the CBC was 7.3 HB, WBC counts of 5,610, and platelet of 274,000 with a D dimer of 495. Creat was normal and trop T was done, which was negative. So shifted to ICU, was requiring high flow inhaled oxygen, had a bilateral crepitations, echo was normal. So underwent CT. So CT had multiple discriminated and conflict patches of consolidation with surrounding ZGOs involving right lung and superior segment of left lower lobe, and minimal reactive right-sided pleural effusion and thickening. So this was the CT of the patient, which we'll be sharing to you. So looking at this CT and CT findings, so ICU team had sent upper respiratory biofire panel. So this was the report of upper respiratory biofire panel, which was showing human metapneumovirus detected. So this was on day 2 of admissions X-ray. Initially, patient was started with high flow nasal oxygen, 60 liters with FiO2 40. Then the respiratory worsening was there, and with the PF ratio of less than 100, initially started 70. On that also, she was not maintaining PF ratio of more than 100. So in view of worsening, ARDS started on methylprednisolone. On prednisolone, methylprednisolone, she improved. So on day 7 we have discharged her. So prior to discharge her, this was her X-ray. So that was my presentation about. Thank you.
Yes. Thank you, Dr. Likhit. I think this is just stating the context here. We have Dr. Bharat Purandare, who has also been active in managing the case. I'm unmuting you, Bharat.
All right.
Sorry, I'm doing it again. Yeah. Please speak.
All right. Just a quick comment, Pushkar, about this case, that the X-ray and CT findings were like pretty non-specific for any bronchopneumonia, and from just seeing at the CT scan or a CBC picture, you cannot say whether this pneumonia is viral or bacterial. It could be pneumococcal, it could be mycoplasma, it could be seasonal influenza, it could be anything. So the first take-home message from this case is that it is a non-specific infection, and only a tertiary care center which has the facility of this multiplex PCR could diagnose, because the human metapneumovirus as a single individual PCR is not available in many of the laboratories except for the research laboratories. So we are having access to this diagnosis only via a multiplex PCR. And even though methylprednisolone was given in this case, it was basically for the ARDS and not for the as a treatment for human metapneumovirus. So we should not take a take home message that steroids are given like COVID in metapneumovirus. It was given because it mandated steroids because of the ARDS protocol. So that was the only final comment about this case, Pushkar, and over to you.
Yes, thank you, Bharat. Dr. Aarti Shade, madam, you can continue on the coordination. You may unmute yourself, ma'am. No? Okay, just give me a moment. You can now.
Yes. Thank you, Bharat, and thank you, Likhit, for that. Shall I ask Dr. Nagvekar to continue with his presentation? Dr. Nagvekar, on to you, sir.
Yeah, I'm just unmuting you. Yes. Yes, sir.
Thank you, Dr. Aarti, and I would like to thank Dr. Pushkar, Dr. Bharat Purandare, and the API branch of Pune for giving me this opportunity on speaking on human metapneumovirus. So I'll just share my screen, and it's you able to see my screen?
You can see the screen.
Yes, okay. So, as Pushkar rightly said that, and good evening, everybody. So, as Pushkar rightly said that there's a lot of anxiety and a lot of seniors, juniors. Always there's a question, ki, what's happening? Anybody, I meet them at HN Reliance or Leelavati, the consultant, they always ask ki, what's happening? What is the seriousness and what is how much is in the air, human metapneumovirus? And because of so much of media and speaking about this, and everybody is worried because initially all of us, when the SARS-CoV came in like in early 21, all of us did not feel that it may be serious, but later on we saw that how it created a havoc in the last 2.5 years time, and then so that's why everybody is guarded and everybody is watchful about what's happening. So today's my topic about human metapneumovirus unfold the mystery and expel the myths is what Dr. Bharat has given me to speak about. And so the outline of my talk is going to be just giving you an overview of acute respiratory infections, the epidemiology, risk factors, and the taxonomy of the human metapneumovirus, the clinical features and diagnosis, how do you make for human metapneumovirus, clinical comparisons, how do you clinically identify, suppose if you do not have a test, then are there certain, clinical parameters which would tell that possibly this could be influenza A, or it could be a respiratory sensitive virus, or it could be, so are there any clinical comparisons, or does the clinical comparison really matter into the clinical outcome of the patients? I think we will see that also. And what are the various treatments which are available or which are experimental for the treatment of human metapneumoviruses and prevention. So also we'll talk about certain vaccines which are into development, some of them in phase 1, phase 2, and whether other similar viral vaccines which are available, does it protect the human metapneumovirus? I think that's all I'm going to speak for today. And if you see the overview of acute respiratory infections, acute respiratory tract infections is the leading cause of morbidity and mortality worldwide. Globally, ARIs are responsible for about 20% of total deaths in children less than 5 years of age in 2000 alone. Moreover, about 70% of these deaths occurred in the sub-Saharan African and the southern regions of Asia, that is, in the developing or underdeveloped countries or the middle income countries, but not high income countries. Acute respiratory infection affects children regardless of their economic status, with similar incidence rates in both developed and developing countries, but with a higher mortality rate in the developing countries. The risk of pneumonia is higher in children in developing countries, 10 to 20% compared to 3 to 4% in developed countries. We will see in one of the papers how it differed from below income countries to middle income countries to high income countries. Does that really matter? We will see in one of the slides. Seroprevalence studies have shown that a higher percentage, 90 to 100% of the children have been infected by the time they are 5 to 10 years of old. That means by the time the child is 5 years of old, they must have, almost 90% of the children have suffered from human metapneumovirus or possibly maybe an RSV. But reinfection can occur throughout the adulthood because it does not give you a protective immunity lifelong. So human metapneumovirus and RSV are considered actually viral cousins, that because they are almost similar in the structure, that belong to the same virus family and are associated with similar symptoms and clinical outcomes. So though they are slightly different, they're cousins, but they have similar clinical outcomes and similar symptoms. The two viruses have overlapping seasonality, with RSV cases often spiking in the early winter months and HMPV spiking in the midwinter throughout the early spring. So always one virus always dominates, and we will see in one of the slides how each of the viruses dominated during their seasons. This extends the active transmission period of these viruses and may result in severe respiratory disease, increasing infections and the healthcare system burden. Among adults 65 years and older, there are approximately 1,77,000 hospitalizations due to RSV and approximately 1,23,000 hospitalizations due to HMPV in the United States each year. The number could be slightly less because of the testing specifically for HMPV may not be happening. Of this population, there are approximately 14,000 deaths from RSV annually, and in addition, studies in adults above 50 years and older, mortality for HMPV has been observed to be similar of RSV. Less is heard about HMPV because it's a new virus which has just been identified in 2001. Actually, it has been there for the last 70 years. Maybe the testing facilities are not available, or many of them, because of the cost factor, it's not being tested, and that could be the reason why less of HMPV or less of RSV is being heard. Similar clinical outcomes like any other viruses, like the clinical outcome would be more or less same like the influenza A, influenza B, or RSV or the metapneumovirus. Almost all will have the same clinical outcome. What's happening in China? So there is a lot of news, and same thing, SARS-CoV started from China and the same thing in China. But the WHO report, which is just a 1 day old, says that it's in the northern hemisphere and possibly the same. It is a winter season, and usually every year they have the same outbreaks of influenza A, which has been the dominant, then followed by RSV and HMP virus. So it's nothing new which is happening there, but we'll have to be watchful to see whether this HMPV which is causing severe disease in some of the cases, which would otherwise also happen in children below 1 year or above 65 years of age. Is it causing more severe disease, or is it spreading more? Is it because of mutation? So far, there is no data to say that HMPV has mutated or it is more severe. I think it's just it's a winter season, and just like other viral illnesses going on in the northern hemisphere, especially in the China northern belt, it is the same thing what is happening. So nothing new happening. We will have to just be watchful to see what's happening new. So human metapneumovirus, it's a review of an important respiratory pathogen. Human metapneumovirus, just like the RSV, it is also equally important. It's a paramyxovirus isolated from patients of all ages with mild bronchiolitis, bronchospasm to pneumonia. It was discovered in 2001 in Netherlands, but it has been circulating for last 70 years. It's most commonly seen in young children below 5 years of age and predominantly below 1 year of age, and more of above 65 years of age in the elderly population. It can cause lethal pneumonia in the immunocompromised, especially hematopoietic stem cell transplant with patients. HMPV is the major etiological agent responsible for about 5 to 10% of hospitalizations of children suffering from acute respiratory tract infections. Human metapneumovirus infection can cause severe bronchiolitis and pneumonia in children, and its symptoms are indistinguishable from those caused by human respiratory syncytial virus or influenza A. So almost minor differences, but it is very difficult to differentiate. Yes, bronchiolitis and bronchospasm is more seen in respiratory syncytial virus and the HMPV compared to the influenza A or influenza B, which we see in our clinical practice. If you see the human metapneumovirus, it's an important new respiratory virus which belongs to the Paramyxoideae viridae group and the subspecies of Pneumoviridae. In this, there are two. One is a pneumovirus and one is a metapneumovirus. The metapneumovirus is the human metapneumovirus, HMPV, and the pneumovirus is the respiratory syncytial virus. Further, HMPV has 4 subdivisions: HMPV A1, HMPV A2, HMPV B1, and HMPV B2, whereas respiratory syncytial virus has respiratory syncytial virus A and B. These are the subtypes which are there. The importance of this, so far we are good enough to detect HMPV1. We are not been able to further speciate to see whether it is a subtype of this. If you see the structure of a human metapneumovirus, it is almost closely similar to the respiratory syncytial virus, except that respiratory syncytial virus has NS1 and NS2, and the M2 alignment with L is something different compared to the human metapneumovirus. So it is almost same, and these two proteins, NS1 and NS2, and the M2 are slightly different compared to the metapneumovirus. If you see the HMPV and RSV structure, HMPV is a 13 kb negative sense single stranded, both are single stranded RNA viruses, which has encoding 9 proteins, whereas the RSV has 11 proteins. Okay, compared to the HMPV, it has got 2 more proteins. Both are single stranded viruses, and I would thank for this slide from IDV24 and Sanofi for taking from them. Coming to the incubation period. So just to know about this virus, we'll discuss about the severity, how is it really concern in our clinical practice and all that subsequently. But let us know something more about the HMP virus. The incubation period varies from individual to individual, but is commonly between 3 and 5 days, just like any other virus. Influenza A also would have somewhere like 2 to 5 days. So majority of these respiratory viruses, the incubation period is more or less same, somewhere between 2 to 7 days. HMPV, human metapneumovirus, is commonly found in the pediatric population with high susceptibility rates in children less than 2 years of old. HMPV infection in adults normally shows only mild flu-like symptoms. Like it would just show mild flu-like symptoms, may not be associated with fever also in patients who are less than 65 years of age. However, in some adults, severe complications such as chronic obstructive pulmonary disease can occur. Something like elderly, it can behave like a COPD because of the severe bronchospasm and bronchiolitis it causes in elderly patients or patients who have got a structural lung disease. But otherwise, in a healthy immunocompetent person, it would just be a very mild flu-like symptoms, rarely may be associated with fever. So fever, unlike the influenza A, HMPV has less, 50% of the patients may not have fever, compared to RSV, 70% would have fever, whereas influenza, almost more than 90% of the patients will have fever. So this is a major difference among the febrile phase between HMPV, RSV and the influenza viruses. Dyspnea is more likely in adults as compared to children. The risk factors which are associated with human metapneumovirus infection include premature birth, young age, that is less than 1 year of age, pre-existing nosocomial infections, and underlying chronic pulmonary, or it could be cardiac, or it could be chronic liver disease or neural disorders, and especially immunocompromised patients like solid organ transplant and predominantly the hematopoietic stem cell transplant. I think this is the major population which the human metapneumovirus would hit is children below 1 year of age, people more than 65 years of age, and possibly with having associated comorbidities. I would say only age factor is not important, but associated comorbidities like renal failure, chronic liver disease, COPD, asthma, more than 65 years, these would be, and also immunocompromised patients, like especially the stem cell transplant, that is bone marrow transplant patients. The average annual rate of hospitalizations, especially, is 3 times more compared to children 6 months to 5 years of age. So those who are less than 6 months of old, as I said, the risk of hospitalization is 3 times more compared to children who are 6 months, more than 60 months of age. The annual rate of hospitalization due to human metapneumovirus infection is equal to that of influenza or parainfluenza 1, 2, or 3. Combined co-infection of human metapneumovirus with other respiratory pathogens are also seen, but especially human metapneumovirus and respiratory virus together. In one of the slides, I'll show you that when you have two viruses together, that is both the virus coming from the same group, the risk for ventilation or severe ARDS is much higher in those populations. Co-infection with human metapneumovirus, which we'll see in many of the patients, like those who have streptococcus pneumonia and atypical pathogen. As Bharat said, whether the CT, the case what was presented, it did detect HMPV virus in the respiratory biofire panel, but yes, it could be having associated streptococcus pneumonia or the atypical pathogen, because the clinical presentation of this would be more or less same. HMPV is most likely, how does it spread from infected person to others? It is the same, it is a droplet infection, just like your respiratory sensitive virus or influenza A. It is transmitted through secretions by coughing or sneezing, and a distance of 3.5 feet, that is 1 meter, is what we require to maintain. And prefer the person who's suffering that he uses protection, that is using mask, so that it doesn't spread to others. Close personal contact such as touching or shaking hands and not using hand rub. I think that is, I think SARS-CoV-2 has really made us learn so much about the infection control practices. How how do we have to handle our patients in the OPD as well as indoor. That hand hygiene is the most important part of your infection control practice, apart from using a mask if it's required. Touching objects or surfaces that have the viruses on them and then touching the mouth and nose or eyes without using a hand rub is again a problem. I think all of us should develop a tick. Tick means any surface you touch in the hospital, whether it's a curtain or the doorknob or a table or anything, you should have a tick of immediately, it should be irritating your hand and you should be searching for a hand rub so that, you are clean from that, and so that a virus or any other illness is not transmitted. So that is what is most important. So what are the clinical, after knowing the incubation period of 3 to 5 days, after knowing that what are the risk factors for human pneumovirus, which is more or less same for any other virus. So this is nothing specific new like the SARS-CoV-2 with what we were really worried. It is nothing. It has been circulating for 70 years and it's been there for last 25 years. And unfortunately, we have been seeing this virus, and I'll show you my data of the hospital, how many human metapneumoviruses we saw, how many were hospitalized, and what was the clinical outcome of those patients. So coming to the clinical features, the clinical manifestations of human metapneumovirus infection are indistinguishable from the respiratory sensitive virus infection, especially in young children. Human metapneumovirus patients are generally diagnosed with bronchiolitis, bronchitis, and pneumonia. So anybody having a severe bronchospasm, possibly maybe having, especially children below 1 year of age, maybe having HMPV, or it could be a respiratory syncytial virus as well. They show common symptoms like fever, cough, hypoxia, in severe cases who have developing ARDS, upper respiratory, or it could be just an upper respiratory tract infection, just like sore throat, rhinitis, rhinorrhea, or maybe laryngitis. Lower respiratory tract infections and wheezing, which is most commonly. The average duration of fever, which is seen in human metapneumovirus, could be anywhere from 2 to 10 days, which is the maximum, with a peak during the course of the illness. Young adults with human metapneumovirus in reinfection shows mild cold and flu-like symptoms with fever in a small proportion. So I think more or less, if you see, the differentiating feature is between, compared to influenza, is the bronchospasm, bronchiolitis, what we see predominantly in HMPV and RSV. It is more or less same. Both go hand in hand and more or less same. Only thing the difference is fever is seen in only 50% of HMPV patients, whereas it is usually a very, very milder sort of infection. Young adults and HMPV reinfection show mild cold. Wheezing is a common clinical symptom observed in HMPV, just like your respiratory syncytial virus infections. HMPV, that is human metapneumovirus infections, can lead to asthma exacerbations in small children and adults with already having an underlying COPD. Human metapneumovirus infection acts as an enhancer of the patients, and COPD are more prone for HMPV infection. What we see in the clinical, actually laboratory investigations, really CBC, what would show is possibly leukopenia with monocytosis, and sometimes possibly with a higher CRP levels, which can confuse us that are we dealing with with a viral infection with a second infection. But normally viral infections rarely unless complicated will not have secondary bacterial infection. This is how it looks like. The milder version, what we see in children 5 years to 65 years, will have just cough, nasal congestion, rhinorrhea, sore throat, sputum production, and hoarseness of voice. The severity, those patients who develop severe infection will develop dyspnea and wheezing. And rarely, these are the respiratory symptoms. Non-respiratory symptoms would be fever and mononucleosis-like syndrome. Some of the patients may develop rashes, but it's very rare to see. Of course, all of us have not experienced so much of human metapneumovirus infection because adult physicians usually, this is more seen in children below 1 year of age, and of course, elderly population more than 65 years of age, what we would see in our clinical practice. This is how any X-ray, whether it's a respiratory syncytial virus, whether it's a human metapneumovirus, or whether it's an influenza A virus, all the X-rays will show similar pattern, and majority of all these viruses, if you see, would have similar bilateral. So first, this slide is specific for HMPV, human metapneumovirus infections. In these 41 patients, what they saw was 80% of the patients had bilateral involvement. Proximal lung involvement was seen in almost close to 100% of the patients, and peripheral localization was seen in 30%. So human metapneumovirus, slightly different, had a proximal predilections compared to the lower lobes. Location, if you see, middle lobe is more involved, and pattern is patchy rather than confluent. Other findings, what we see are the bronchial wall thickenings, which is again seen in 100% of the patients, because bronchial wall thickenings will cause bronchiolitis and will also cause a bronchospasm. So specific features are that it has bilateral, it has got a proximal involvement, it has got production for lower lobes, and also it has bronchial wall thickening. So these are the few of the features which we see in human metapneumovirus and also seen with respiratory syncytial virus. Now coming to the various papers what I went through, and in this paper, which was a New England Journal of Medicine in 2004, which talked about human metapneumovirus and lower respiratory tract infections in otherwise healthy infants and children, what they found was 12% of the respiratory, those people who came with a respiratory tract infection, human metapneumovirus was seen in 12% of the children, and especially those who were less than one year of age. That is, average was 11.6 months, but what was seen was predominantly 12% in less than 1 year. It was the human metapneumovirus infection. Now coming to the next paper, which talks about global burden of acute respiratory infection associated with human metapneumovirus in children under the age of 5 years. In 2018, it was a systemic review and modeling study. And what we saw that this was a review of 119 studies. And what they saw was infants younger than 1 year of age have disproportionately high risk of severe human metapneumovirus infection across the World Bank income regions. Infants younger than 6 months in low income and lower middle income countries are at a greater risk of death from human metapneumovirus associated ALRI than the older children and those in the upper middle income countries. The next slide will clearly show you that this is the top one on the left hand side is the lower middle income countries. This is the upper middle income countries, the center one, and HIC is the higher income countries. If you see the the case fatality rate was 4.5% in the lower middle income countries compared to 1.7 in the upper middle income countries and 0.4 in the higher income countries. So again, deaths, if you see, the number of deaths was also higher in the lower middle income countries compared to the higher income countries. So it clearly says that this respiratory syncytial virus or the human metapneumovirus, I would say, has got higher mortality for children below 6 months of age, and this is 0 to 5 months, and it is basically having even the high case fatality rate. When we see 6 to 11 months of age, the case fatality rate in lower middle income countries and the higher middle income countries were more or less same, and it did not really differ that much in both the countries, both the groups. So HMPV and RSV below 6 months of age has definitely been a concern for, and it has been the concern over the last 24 years. It is nothing new that it has started in December 24 or it has started in January 25. It has been there for anything. The pediatricians and neonatologists been handling these cases, and they have much more exposure to these cases. So what about diagnosis of these viral respiratory disease in older agents? If you see this from paper from Talbot, which talks about that all the viral infections, PCR is the way to go forward for the diagnosis of these testing. We do not have serological testing. We do have serological testing, like we have some antigen tests for influenza A, B, but believe me, all these serological testings would take a day or 3 or 4 days more. But PCR is the fastest way because you will get your result within 2 hours. That is, but only thing is it's very, very expensive because we do not have dedicated we do not have a human metapneumovirus dedicated PCR. We have the flu RSV gene expert which is there, which is much more reasonable, but we do not have a flu RSV human metapneumovirus gene expert. Maybe I think after this hype which is going on about human metapneumovirus, they might add to this gene expert of what is being done as RSV flu gene expert. They may add HMPV also this virus to this gene expert. But otherwise, the way forward to diagnose any of these viral infections, if you see 3+ PCR is the way to diagnose any of these viral infections. And why is it that, forget about human metapneumovirus, even the RSV virus testing, if you see in USA, in all hospitalized patients, less than 25% of the people have been tested for RSV. Those who actually had RSV, the testing itself is less. Maybe the cost factor, because I think if you really want to check up for human metapneumovirus, you'll have to do a respiratory biofire, what Dr. Bharat Purandare's student showed, and that cost from hospital to hospital varies. But I would say it is an average of 10 to 15,000 rupees is the cost of the respiratory biofire, what has been done to detect a HMPV virus. That is it really required? That's the whole question. So another, now we'll come to comparison about, the human metapneumovirus. How different, or is it different from the respiratory syncytial virus infections, or is it different from influenza A virus? We do not have the comparison with SARS-CoV-2 because SARS-CoV-2 was completely a different virus, and this virus behaves almost similar to RSV. And if you see comparison of respiratory syncytial virus with a human metapneumovirus for patients who are, I'm specifically talking about 65 years and age, the one which has been highlighted. If you see the inpatient for RSV infection was around 19%, whereas for human metapneumovirus was around 23%. So more or less, the admission rates for inpatient was around 21%. So 21 versus 19%. So it was almost more or less same. But the emergency department, that is number of cases for RSV and the OPD basis, were much more, 34% compared to 23%. But that is not very important for us. What is important is how much does the RSV infection patients require to be admitted. That was around 19%. That is for people 65 years and above. And same for your HMPV also, it was 21% for those above 65 years who required to be admitted. Now, if you see this seasonal variation, on the extreme left-hand side, you will see that from January, you will see the virus which predominates is the respiratory syncytial virus. In February, it's also respiratory syncytial virus, but you'll see that the influenza and the HMPV started coming up, and subsequently the respiratory syncytial virus numbers start decreasing, and the human metapneumovirus and influenza predominant. So it's more of a seasonal. It is always respiratory syncytial virus first to come and followed by the human metapneumovirus and the influenza simultaneously, or maybe influenza subsequently, which predominates. But it's always to begin with early winter is the respiratory syncytial virus and followed by the human metapneumovirus. Now coming to the clinical features, if you see this slide, very important. What are the clinical features which are different between the respiratory syncytial virus, human metapneumovirus, and the influenza-like virus? If you see breathlessness, dyspnea, if you see, is a predominant feature, 87% in the respiratory syncytial virus, almost 87% in human metapneumovirus, only 75% in influenza-like virus. If you see fever, it is seen only in 50% of human metapneumovirus, whereas around 90% of the influenza A virus will have fever. So fever is not a very, meaning one out of two would have fever, whereas influenza, 90% of the patients will have fever. What about myalgias? Myalgia, again, if you see, is a predominant feature of not respiratory syncytial virus or human metapneumovirus. It is a predominantly seen in myalgia, and fever is predominantly seen in influenza, high-grade fever. Whereas fatigability is almost seen in all the three conditions, but severe myalgia would be seen predominantly in influenza illness. If you see the ICU admissions, it is more with human metapneumovirus infections and the respiratory syncytial virus infections compared to the influenza A. And the reason is, why is it the influenza, the number of admissions are lesser and the mortality and the mechanical ventilation is also lesser, is because there is a treatment, definitive treatment for influenza A and B, specifically influenza A, where oseltamivir works beautifully. Whereas for your human metapneumovirus and respiratory virus, syncytial virus, those below 6 months of age and those above 65 plus having comorbidities will be at risk for hospitalizations. In some of them, that is less than 10% compared to the influenza, because influenza, there is a definitive treatment available for this virus. When we have the characteristics, this paper talks about characteristics of human metapneumovirus infections in adults. And again, it compares between human metapneumovirus infection, influenza, and the respiratory syncytial virus. So this paper compares about people who are about 65 years of age. If you see that the number of patients who are predominantly were the human metapneumovirus and the respiratory syncytial virus. And what is more important is that if you see that chronic disease, that is at least one chronic disease with above age of 65 were predominantly seen more in respiratory syncytial virus and the human metapneumovirus compared to the influenza viruses. So if you see 65 above, and one of the chronic illnesses is one of the major risk factors for respiratory syncytial virus and the human metapneumovirus compared to the influenza A. So this is one very important differentiation between influenza A and the human metapneumovirus and the respiratory virus. This is the data from one of our hospitals, which we saw that the number of respiratory syncytial virus, the human metapneumovirus, which we saw was predominantly in the monsoon season compared to what we should have been seen in the winter season. But believe me, in the this December, we had 0 cases. November, we had 1 cases. And only in August and September, and I spoke to my friend in another hospital, also they said the same thing, that maximum cases were seen in the monsoon. So we are not following the western, so southern hemisphere is not following the northern hemisphere. Our cases, what we have seen, were predominantly only in 2024. But if you see 22-23, we did not have so many cases. And what were the risk factors? So those patients who required to be admitted, if you see all those patients who required to be admitted, 2 patients were less than 1 year of age, and the rest of them were, if you see in IPD or 9 age, 1 year were 2 patients, that is less than 1 year. 60 to 70 years of age were 3, and more than 80 years, again 3. So I think age becomes a predominant risk factor. And if you see extreme right, asthma, diabetes, chronic liver disease, cardiac arrhythmias, so there's always one associated. If you leave the first 2 columns, that is the 1 year age, if you see the rest of all the patients, except the first 2 and the last one, that is 11 years, you will see that all the other patients were above 60 years of age and had at least 1 or more comorbid conditions which were requiring hospitalizations. But unfortunately, none of them had a mortality and all of them did well. Of course, there's no specific treatment which was available. What happens when you have a dual infection in infants, like, if the patient who has got human metapneumovirus and also has a human respiratory syncytial virus? So this was study which was done, and what they found was that dual infection with human metapneumovirus and respiratory virus confers a tenfold increase in relative risk of admission to a pediatric intensive care unit for a mechanical ventilation, and dual infection is known to cause severe bronchiolitis. Coming to the treatment part. So what are the treatments for human metapneumovirus infections? There is specifically treatment for human metapneumovirus, just like your respiratory syncytial virus, is only supportive. Unlike respiratory syncytial virus, in US, vaccination is available and is for all above 65 years of age. And for those pregnant women, they can take the respiratory syncytial virus vaccine so that the antibodies are transmitted to the infants. So this is what. So for RSV, there is a vaccine. For HMPV, there is no vaccine, and it is all supportive line of treatment. But once a person develops respiratory syncytial virus, it's also supportive line of treatment. Ribavirin plays some role. Oral or IV has been in experimental and shown to be some role. A combination of ribavirin to those patients who have severe ARDS and breathlessness, or on ventilator, or on high flow nasal cannula, possibly ribavirin with immunoglobulin, IV immunoglobulin has been shown to be promising results. So I think this is one treatment which you can possibly try in your treatment if your patient is really at risk for just short of ventilator, or those patients who are on ventilator. What about monoclonal antibodies? They're all experimental, and there is one MAB 832 and 834 which has been experimental but not promising as such. What about palivirmuzab, which works beautifully in respiratory syncytial virus infections as a prophylactic for children? It has got no role for human metapneumovirus. Though both are cousins, palivirmuzab does not support the human metapneumovirus. There are various other treatments which are experimental, that is fusion inhibitors. There are various vaccines which are, that is the particle one, the live attenuated vaccines. So many vaccines are in phase 1 and phase 2 trial. The next slide we will just run through what are the various vaccines which are available. And also there is in phase 2 trial a dual vaccine which is in development, because if you have a vaccine for respiratory syncytial virus, why there is no vaccine for human metapneumovirus? And that is because of the absence of the two nucleoproteins, the N1 and N2. And there is a dual vaccine which has been in development in phase 2 trial completed. Now going for phase 3 trial, which will be protecting all after the vaccine has been given. The protection starts after 1 month, and it protects both from human metapneumovirus and the respiratory syncytial virus. So these are the various vaccines which are promising: the live attenuated vaccine, chimeric vaccine, and the virus-like particle. But the main question is, we cannot give live attenuated virus to infants below 5 years, and also to basically elderly patients who are having comorbidities above 65 years of age. So that's a big question for a human metapneumovirus with a live attenuated virus. So we will have to wait for chimeric vaccine or possibly the virus-like particles, which will be safer. So what is the prevention? Prevention is just hand hygiene, avoid touching the eyes, nose. Standard precautions, what we do for influenza A virus or SARS-CoV-2, nothing different. But if some person is sick, better to stay home for 3 to 5 days or at least 48 hours after the symptoms subside completely. So in summary, I would say human metapneumovirus been there for 70 years, but detected in 2001 and behaves similar to other circulating viruses. It is nothing new. It is not severe. It is the same way it is behaving. So so far, no mutations has been detected. And I don't think there's any reason to worry, but we'll have to be very watchful, because just like we'll have to be watchful to see whether really it's a mutation, because it's too early for us to comment on this. Human metapneumovirus causes mild URTI. So it is not new. It has been there for a long, long time. So human metapneumovirus causes mild URTI in immunocompetent patients, but in children, it will just cause, in immunocompetent, it may not also cause fever, because fever is not a very common feature. It's seen only in 50% of the patients. But in children less than 6 months, it is known to cause severe ARDS, bronchiolitis in 10% of the patients. Human metapneumovirus spreads from person to person and surfaces to person, just like a droplet infection. If a person is positive and it requires hospitalization, You don't require specifically negative isolation. You just require a single room or a negative isolation if it's available. Symptoms include cough, fever, nasal congestion similar to mild infections and shortness of breath in severe cases. Your healthcare provider can test. However, the cost is 10 to 15,000 for HMPV as of now, unless we have the RSV flu gene expert which is available, which may be in future still to come. But there is no specific treatment. Maybe ribavirin in severe cases, along with plus minus immunoglobulin, the IVIG may be of some use. Prevention measures include hand washing, cleaning surfaces, and staying home when sick. Thank you for your kind attention. I think I will stop my screen here.
Great. Thank you, sir. I think this was a very reassuring and a very informative lecture for all the physicians, and very useful in terms of their communication with the patients as to how they can actually cause less panic among patients with true knowledge. Dr. Shahade, madam, yeah, over to you. I'm unmuting you, just a minute. Or you can, yes.
Wonderful. Thank you very much, Dr. Nagvekar. That was a very exhausting and a very beautiful lecture. And I'm sure that most of our fears are allayed. I would like to, Bharat, Parikshit and Amit, our ID specialists, whether they would like to add something to it from the local point of view, if they have seen any cases or whether they have seen any change in the trend that has already been described by Dr. Nagvekar. Bharat?
So I just request you to raise your hand so that I can unmute you easily. So your name comes on the top. So Amit is already unmuted. So Amit, you can speak.
Yeah.
Thank you, madam. Actually, Nagvekar sir has covered most of the points.
Yes,
The
I agree.
only thing I would like to say is that we should all go and read the China CDC report. If you go and read the China CDC report, it clearly says that there is a winter surge of 4 diseases, and majority of the surge is because of influenza. The rest 3 viruses are rhinovirus, RSV, and human metapneumovirus. Most of it is concentrated in northern China. I don't know who has just picked up one virus from the 4 and run with the story saying that there is an increase in human metapneumovirus. If you look at the yearly data, because we are not testing properly, if we test, we will also find human metapneumovirus in India. So it's not a new virus. We all have some amount of immunity to it. Yes, the immunity will fall once we reach above 65 years of age and we get immunocompromised. But as sir has rightly said, there is nothing alarming which is happening. And the surge of human metapneumovirus normally in the northern hemisphere is in February, March. So the next 2 months we need to watch out. But I still feel that it is more sensationalism than truth.
Thank you very much for that comment. Bharat, would you like to add something to it, or Parikshit? Yes, Bharat, go ahead.
Yeah, so thank you, Dr. Nagvekar, for accepting our invitation and at a short notice agreeing to come onto this platform and enlighten us with your thought and your experience from your both hospitals in Mumbai was kind of reassuring to us that it looks like a seasonal infection rather than going to take a epidemic or so-called pandemic form. Because as we all know, for a viral infection to become pandemic, there are certain necessities, like it should be a new virus like how COVID was, or it should be a virus which is equipped with special abilities, such as like COVID had an ability of adhering to the mucosa, causing thrombosis and eliciting a very high immune response, causing a immunological storm. And all our population was susceptible at that time, and nobody had experienced this virus at that time, and therefore it was a pandemic. Now this HMPV has been there, and for last 3-4 years we have been encountering HMPV. Whenever we are sending multiplex PCRs, we are encountering it. So it's not like something new. The case which was presented by Likith some time back was of September of 24. So it's not like we are seeing it for the first time. and because it affects children more, I believe the antibodies would be there in the population, and it's not like a something totally new like COVID that we had. So it's unlikely that this virus is possibly going to take a pandemic form. However, as you had already emphasized, Dr. Nagvekar, that we need to have those cough etiquettes are somehow which we are now forgetting. The amount of hand hygiene we used to do in COVID times, and use of mask that we used to do, that we are not that much doing now, isn't it? At that time, we were doing it too much. So again, I think that reiterates the fact that whenever a respiratory infection surge happens, our infection control should be improved. That's what I believe. And there is no specific treatment for this virus, neither steroids, nor ribavirin, nor IVIG. Nothing has been like proven to be a full-fledged treatment for this virus. Maybe some drug will come after some time, and we will be able to use it. But till that time, prevention, respiratory hygiene I think these are the ways to go. One important, interesting point that I wanted to bring for discussion was whether this infection brings upon secondary bacterial infections or fungal infection, that what we saw in COVID. Like after COVID, we had a mucor epidemic, or we had a COVID-associated pulmonary aspergillosis. I think it was because of the immunomodulatory effects of the COVID. Whether it comes after HMPV also, one has to definitely see.
So Bharat, so about this, I think there's no data about having a invasive fungal disease. What we normally see with influenza A virus, normally we see IAPA, that is influenza associated pulmonary aspergillosis. So there's no data about this, and I don't think we have any data about respiratory syncytial virus also causing an invasive fungal disease. But yes, I think those people who develop a respiratory syncytial virus and the human metapneumovirus are usually those who are not having an adequate immunity developed. So just like children below 5 months of age, they don't have their immune system well developed. And all those people above 65 years of age and having at least one or more comorbidities will be again having some sort of T cell dysfunction, even if your CD4 count is low. And those patients who are immunocompromised also, or those who are on like hematopoietic stem cell transplant, where the CD4 count is not developed up to 1 year or so, maybe again at risk. So I think T cell dysfunction is a major risk factor again for your RSV and HMPV. Yes, and so they will be at secondary risk for bacterial infection if they have a prolonged hospitalizations in the ICU or ventilator. So that is what, but I think we'll have to have more experience, Bharat, about this virus to tell us more, because, but it has been, unlike what you correctly said is that SARS-CoV-2 was completely a new virus, it was just like MERS, but this has been there for 70 years and only diagnosed, say, 24 years back. So it has been there. So there would be definitely some sort of collective immunity, which must be, all of us may be having it. Of course, we don't have the serological tests available, but it's been there for some time. Unless it's mutated, then it's a different story.
Yeah, Dr. Parikshit? Dr. Parikshit, would you like to add something?
Yeah, yes, ma'am. So good evening, everyone. As my 3 ID colleagues have been saying that, this virus has been around for a very long time, and it has just garnered a lot of press attention at this point of time. Few points like Dr. Nagvekar said, this is closely related to RSV. So a lot of the clinical findings that we see in metapneumovirus, and we've been seeing metapneumovirus sporadically in last few years, especially people who see lung transplant patients or people who see bone marrow transplant recipients, we do find some cases of human metapneumovirus because, of course, we test more in these patients, and some of them also tend to worsen. So lung transplant patients, for example, can have graft dysfunction, or what we call a CLAD, from respiratory syncytial viruses or metapneumoviruses. So we've been seeing this group of viruses in the last few years. It's not as if it's completely new. Dr. Nagvekar showed his own hospital epidemiology. So we do see sporadically, we do get a couple of months in between wherein we suddenly see 3 or 4 cases of human metapneumovirus in our settings as well, especially in the BMT unit. So we've been seeing that. Like he said, interestingly, these viruses, steroids and lymphopenia actually in the transplant settings have been associated with worse outcomes. So even amongst the comorbidities, T cell dysfunction, lymphopenia, and steroids, these are more commonly associated comorbidities. Neutropenia, not so much. So not these are not viruses that you would be particularly concerned about even in the setting of febrile neutropenia. So for example, even in our AML patients who get metapneumo or RSV, we don't really use even ribavirin in our AML patients who get upper respiratory tract RSV. So the main risk really lies in patients who have prolonged T cell dysfunctions, prolonged lymphopenias, and steroid usage. So that has been the pattern for these kind of infections. As far as fungal infections is concerned, I mean, secondarily, there is very, very sparse data, but slightly more for RSV than metapneumovirus. Last year there was a case published wherein a transplant recipient actually got invasive fungal infection post metapneumovirus, but that was really one of the earliest case reports. So as Nagvekar sir said, it's too early for us to build any of this information about secondary fungal infections. But from so far what we have seen, and like he said, these viruses have been around for a number of years, discovered officially in 2001, but has been around for a number of years. So far the published literature doesn't really point to an increased risk of invasive fungal infections, doesn't point to an increased risk of a cytokine excess syndrome, doesn't really point to an increased risk of endothelial damage as well, which is reassuring because some of the complications that we saw in COVID patients like pulmonary embolism, we expect much lesser, in these patients. So really the main problem so far with this group of viruses, RSV and metapneumo, is, in immunocompromised patients, T cell dysfunction, lymphopenia, lung transplant recipients wherein they can cause chronic allograft dysfunction, and sometimes BMT recipients. And I'm talking about the adults, of course, not the pediatric population. And BMT recipients wherein, it can go on to involve the lower respiratory tract, wherein we use scoring systems to see who would benefit from ribavirin and so on. But in general, for even a lot of our other patients with comorbidities like diabetes or hypertension, I don't think it's too worrisome because these have been around for a long time, and we very rarely see severe manifestations of metapneumo or even RSV. Sometimes exacerbation of chronic obstructive airway disorders can be seen, but beyond that, we don't see much of mortality or even severe morbidity with these viruses. So that is reassuring. So I think, like always, we should keep looking out for manifestations and observations, but I don't think we really need to panic because these have been around for a very long time.
Yes. There are one or two questions which I would like to ask the eminent panel. The one is that for how long the patient will remain infected? That means, of course, during incubation period, and then the patient is diagnosed to be having the infection. For how long would the patient be will remain infective in the sense he's capable of transmitting the disease?
So normally I think 5 days, that is what 5 to 7 days is what is expected. But I think once the fever abates and I would say another 48 hours should be good. But some of the infants, who have developed acute respiratory distress and breathlessness and severe bronchiolitis, they can keep shedding it maybe for a couple of weeks also. That is what has been reported.
All right. Like how we used to have in COVID, will these patients will become, say, false positives? RT-PCR would be false positive in a patient who has suffered from COVID or who had subclinical infection. So if you do the RT-PCR, it would be positive after some time, sometimes even after 2 to 3 months. So is that likely to occur in these cases also?
So we would expect the PCR to be positive for some time, but the time frame for how long it would be positive, I'm not sure. Parikshit or Bharat, I'm not sure. But up to 6 weeks, definitely, yes, it will be positive.
Yes. Okay.
So in immunocompromised patients, there can be prolonged shedding. So I wouldn't call that PCR false positive PCR. It's just that we don't know how viable the virus is, at some point of time. Even in COVID, it took a long time to define cycle thresholds for viability. So PCRs being positive for a long time and shedding is known in all these viral infections. In fact, there are BMT recipients who continue to have metapneumo and RSV positive in their respiratory panels for weeks after a clinical infection.
Okay. So that is not synonymous with infection. They just keep shedding their virus. That's all, right?
Yes.
Okay. Then, well, another very common question, should we ask the patients to use a three-ply mask or are we back to N95?
So I think any patient who has got a respiratory tract symptom, whether a patient at home or office or hospital, I think three-ply mask is good enough. You don't really require. So it's more of a droplet infection, and I think that should suffice. Uh, that's what I feel. Parikshit, what do you feel? And Bharat?
Yeah, I agree, sir. With especially with the compliance factor, because these are not these are viruses which have been always around. So it's a long battle. So it's we have to also look at the compliance. So I don't think N95 in terms of the cost as well as compliance is feasible, and it adds much as far as whenever there is a droplet infection, that is the problem. Then it's not going to really add much to the uh,
Pushkar, are there any raised hands? I
Yeah,
did see a few.
Dr. Rishikesh had actually raised his hand, but I think he's dropped off. I'm just checking.
Yeah.
Rishikesh, are you there? If you want to ask your question, I think he's left. So,
Okay.
okay,
Yeah,
I
there's
think
Sagar
there
Gupta.
is Sagar Gupta. Yes, I'm unmuting you.
Yes.
Just a minute. Dr. Sagar, you can unmute. Yeah.
Yes, it was a very nice discussion done here, and many questions are already been answered from experts. Thank you very much for that. I just wanted to ask, sir, apart from RT-PCR or PCR test for metapneumovirus, is there any IgM or IgG antibody test is also advisable, or it is available?
It is not available. I think presently the human metapneumovirus is only into the respiratory biofire panel. But yesterday I saw one advertisement in Mumbai which spoke about PCR for human metapneumovirus 4,800 rupees. Otherwise, the respiratory biofire takes 10,000 to 15,000. So I don't know about this, but no serological tests are available to the best of my knowledge.
Thank you, sir.
I think Rishikesh has come again. Rishikesh?
Yeah, I've unmuted you, Rishikesh. Just a moment.
And Pushkar, after Rishikesh, Kadam sir and Kakrani sir also, they will.
Yes, yes. Rishikesh, you can unmute yourself. Are you not able to? Because I'm unmuting you. Okay, maybe there's a problem with Dr. Rishikesh's mic. So,
Dr. Parikshit Prayag also has raised his hand.
yeah, actually, he spoke, but
He spoke,
Parikshit,
okay.
if you want to speak more. Okay. So, I'm just, yeah, Dr. Kadam sir, yes, you're unmuted. You can please add your comments. Kadam sir, you are unmuted. Not able to hear him.
No.
Kakrani sir?
Okay. Kakrani sir, could you just raise your hand so that I can quickly unmute you? Yeah, I can see you now. Yes. Unmuting you.
Okay, no, nothing from my side. Only I read a newspaper report that BJ Medical College reported 17 cases in the before December. So that means they have been doing it and they have been detecting it. So I think, as Dr. Nagvekar told, that it has been there since long. Only question is now it has been hyped because of China situation. But Dr. Nagvekar, do you have a data that how many of them are critically ill in China? Any first-hand information?
So I did go through the CDC, WHO, China report, CDC China, like what Amit said, and so it is just behaving yearly like the any other virus, and the predominant virus, as Amit Dravid said, the circulating virus is influenza A, and followed by the other viruses like the respiratory syncytial virus, human metapneumovirus, and the rhinovirus. So there are some hospitalizations are bound to occur in the comorbid patients and the in the infants below or children below 6 months of age. But exact number I was trying to find out, but I couldn't get the exact number. What is the mortality or what is the number of patients admitted? But what have been the latest report from China is that from the CDC, it is just like any other winter virus which is going in the northern hemisphere and predominantly seen in the northern side of China. So no specific data as such. But it is nothing that the human metapneumovirus is predominating over the other virus. In fact, it is the influenza A which is the predominant virus. In fact, even in Mumbai, we are seeing influenza A predominantly now, and we are not seeing a single human metapneumovirus. According to my data, also, if you see in November there was one case, and in December 0. Thanks to Dr. Sashikala from our hospital and Dr. Anusha, who piled up the clinical data for me, how many indoor and how many outdoor and how many. She is my clinical physician assistant who helped me to pile up the data.
Dr. Gulati, madam, you have a question.
Yeah, sir, I have a patient who has just come back from China today and traveled extensively because his business is he deals with some machines there, and he said there was no masking anywhere, there is no news anywhere about the virus, and wherever he traveled there was no awareness of this kind of epidemic sort of a situation or something. It's all like the airports were fully crowded. There was no masking, nothing.
In fact, I was surprised the Sensex crashing down because of one human metapneumovirus. Now it's, we have been seeing this virus so much in September and August. So many cases were there. And so now, I don't know, it's going to be every case, it's going to be there because it's been there for years. So how can we not have that, So.
No, he was saying that his family from Pune was more worried than what the Chinese people were over there.
So that makes us more comfortable, madam.
Yeah.
I think all the questions are exhausted. Pushkar, from my side, there's no more queries. Nothing.
Only I think Rishikesh wanted to ask, but then he's not able to unmute.
He's not able to answer.
But if you can type Rishikesh, but
yeah.
Otherwise, yeah. Dr. Kadam sir actually is unmuted, but we are not able to hear him.
Yeah.
Okay, I'll try unmuting again.
I think we had a very fruitful evening today, and
Kadam sir, I think he is able to speak.
He's able to speak. Yeah, Dr. Kadam sir, to you, sir.
Hello, good evening. There was some problem with the audio. Good evening, Nagvekar sir.
Good evening, sir. Good evening.
Yeah, it was a pretty nice discussion and nice session. The only anxiety which we all have is Corona was known, but COVID became new. So whether there is any changes in metapneumovirus, but it is supposed to be more stable than Corona. Corona has frequent mutations, but we don't expect so with metapneumovirus. That was one thing. And I think we have seen metapneumovirus in plenty. As far as BioFire is concerned, there was some concern about it because when I tried to get BioFire into government setup, microbiologists had opposed it, considering the issue of sensitivity and specificity. We are getting combined infections. As far as RSV concerned, RSV we diagnose second week bronchospasm after URTI is RSV. So metapneumovirus behaves same way as a second week bronchospasm or bronchospasm come upfront as such. So that is not clear as such. And one of our corporate hospitals had an epidemic of human metapneumovirus in residents, especially working in pediatric ward 2 years ago. And they were thinking of COVID, but all of them turned out to be metapneumovirus. The fatigue part of it was much more than what was expected with metapneumovirus. That was the observation as such. Any comments?
So no comments. I think you must have been seeing much more of these bronchiolitis and all that in the pediatric population than what would we see in adults. It's more of a disease of the below 6 months of or below 1 year of age, and not really because even if the adults are getting it, it's so mild that they don't even get fever. It's just some URTI, some laryngitis, some sore throat, and they're quite okay. And I think cross immunity must have been developed in many of the people.
Yes. Dr. Rishikesh actually has a question where he asks if there is any increased risk for severe disease during pregnancy.
So I think whatever data it showed, we did see influenza A being there in the pregnancy, but we did not see any of the case reports for RSV or human metapneumovirus in the slide which I had shown, where we were discussing about the comorbid conditions. So there was one slide about immunosuppression below that and pregnancy. In the pregnancy for RSV and HMPV was 0, whereas for influenza there were cases seen.
Right. Parikshit, you raised your hand again. You want to add something? Right.
No, I was just wanted to say that, like Nagvekar sir was saying, there is not much about pregnancy, and at least from what we know so far, the risk of vertical transmission is also pretty low. So I don't think it's going to be too different. Again, there are case reports wherein pregnant patients who have had obstructive airway disease, it could be a little tricky, but that's perhaps more to do with the obstructive airway disease than the pregnancy.
Yes.
I think that's all, Dr. Mukund.
Yes,
Yeah.
I think.
On to you, Doctor. On to you, Dr. Mukund.
Yes. Thank you very much, Nagvekar sir. As Dr. Bharat said, I think you got a call yesterday only. I only had requested him to speak to you because we thought Mumbai we will get much more news than Pune, but now because Pune also has become a global city, Pune is getting earlier cases than Mumbai also. But overall, it was a very nice discussion, and thank you very much to you, Bharat, Parikshit, and Amit Dravid, and thank you, Shahade madam, for raising this particular query, and you only asked me to arrange this particular meeting. Many people were also asking, but you were insisting about this. I think overall it was a very nice discussion, and after a long time, so many people joined in. Almost 90 people joined in this particular meeting. Pushkar, over to you.
Yes. So you can see that the meeting has been recorded. So we will keep this for reference, and we will also share it with people who could not attend. So I think it's been a great start of 2025 with so many, almost 80, 90, 89 people attending this educational activity of API Pune. So thank you very much, Nagvekar sir, for being the opening batsman for 2025 for API. And it was a pleasure to listen to you and get to watch. So
thank you very much. And I invite you all as a organizing chairperson and the secretary for Clinical Infectious Disease Society. We're having Clinical Infectious Disease Society conference in Mumbai, 11 to 14 September. Actually, I forgot to put on that slide. So just please block your dates. I think Bharat Purandare and Parikshit would definitely reach out to all of you. 11 to 14 September 2025. It is at NCPA Mumbai. and we look forward to see you all for that conference.
One announcement this particular month, we are going to have 3-4 different meetings. One is on 19th. I will announce the agenda of the 19th meeting on Sunday, and thereafter one meeting will be on 24th. And our API meeting this time, because it is a last Wednesday is on 29th, we are going to conduct API meeting on 29th, and this time we are going to discuss the medical legal aspects. So all are requested to join in for that particular meeting and all the other meetings. Thank you very much.
Thank you very much, sir.
you.
Thank you very much, sir, and all that.